I'm Dr. Michael Dobryansky. I'm a board-certified plastic surgeon and a partner in the Long Island Plastic Surgical Group. A nipple-sparing mastectomy is a type of a mastectomy that preserves basically the entire skin envelope of the breast. So all the skin and the areola and the nipple itself remain in place after the mastectomy is completed. So there are many differences between skin-sparing mastectomy and nipple-sparing mastectomy, but in my mind, one of the most important ones is the most natural appearing results. A lot of patients come in and say that they want natural-looking reconstruction. This is where a nipple-sparing mastectomy typically comes in. A nipple-sparing mastectomy looks and feels typically in the most natural way and the closest way to the original breast. In fact, in a lot of patients, the results of a nipple-sparing mastectomy truly approach the results of a breast augmentation, when the woman obviously maintains her breast tissue, which is augmented either by an implant or another method. The main advantages to the nipple-sparing mastectomy are the preservation of the footprint, the size, the height, and the volume of the breast. So if a woman who's about to undergo a mastectomy desires to keep the volume of her pre-mastectomy breasts, the nipple-sparing mastectomy usually allows for direct-to-implant reconstruction, which can in one step maintain the volume and shape of the female breast. Most of the sensory function of the nipple is lost after a nipple-sparing mastectomy. The reason for that is because the nerve supply to the nipple comes towards the nipple within the substance of the breast. Nipple functions such as arousal, such as sensitivity to cold when the nipple becomes erect, is typically lost. I am frequently asked where the incisions will be for a nipple-sparing mastectomy, and obviously there are many different choices for the incision, which depend on the size and volume of the breast, but typically speaking, an incision for a nipple-sparing mastectomy is located in the inframammary fold, which is a fold where the breast tissue meets the chest wall. The cosmesis of that incision is such that it stays hidden most of the time and in most situations, and it is the most natural appearing reconstruction. The nipple-sparing mastectomy is effective in both treating and preventing breast cancer. However, not everyone is an excellent candidate for a nipple-sparing mastectomy if they have a diagnosis of breast cancer. So when it comes to prevention, the nipple-sparing mastectomy is effective. And it has been shown to be equally effective to the skin-sparing mastectomy, for example, in terms of how effective it is in preventing breast cancer. The tissue behind the areola and the nipple typically is biopsied separately during a nipple-sparing mastectomy to make sure that there's no cancer present in that specimen, in which case, obviously, the patient will no longer be a candidate for a nipple-sparing mastectomy. A good candidate for a nipple-sparing mastectomy is a woman who is about to undergo a mastectomy for either preventive purposes, such as a BRCA1 or BRCA2 genetic carrier, or a woman who has a diagnosis of early or relatively early stage breast cancer, which is located more than 2 centimeters away from the nipple areola complex, is less than 2 centimeters in size, and has not metastasized to the lymph nodes. Also, it is important to note that the shape and the size of the original female breast does play a role in determining whether a woman is a good candidate for a nipple-sparing mastectomy. For example, a large breast with some droop, or ptosis as we say, may not be as good of a candidate for a one-stage nipple-sparing mastectomy because the blood supply to the nipple and areola complex is what we call a watershed blood supply, which means that the blood supply to the top of the breast, where the nipple and the areola complex are located, has to travel a pretty long distance from the base of the breast, since the blood supply from within the gland is gone when the gland is removed. Therefore, that blood supply can struggle in terms of providing adequate blood flow to the nipple. So there have been some developments in two-stage nipple-sparing mastectomies, when a woman undergoes a breast reduction procedure done in a fairly standard with a fairly standard technique of breast reduction, approximately 3 to 4 weeks prior to the mastectomy. That allows for a smaller breast to be created and then for the healing to take place, so that the breast 3 to 4 weeks down the line can be treated as a breast without ptosis, and the woman can undergo a breast-sparing mastectomy. So the patients who are not good candidates for nipple-sparing mastectomy are patients with advanced disease, either systemic disease that has progressed to either lymph node or distant organ metastases, or the patients where the tumor itself is located within 2 centimeters of the nipple areolar complex, or patients whose tumor involves the nipple areolar complex or involves skin, which again upstages their diagnosis typically to stage 3 and above, and therefore they are not good candidates for nipple-sparing mastectomy. So the mastectomy and a nipple-sparing mastectomy is obviously a combination procedure, which consists of the mastectomy itself and the reconstructive step. Usually, both surgeons, the surgeon performing the mastectomy and the surgeon performing the reconstruction, will meet together and talk with the patient before proceeding to the operating room. And then obviously the surgeon performing the mastectomy starts the operation. Most of us have established teams with the mastectomy surgeons, and the workflow is organized in such a way as to minimize the time that the patient spends under anesthesia. So what that usually translates to is, once the first mastectomy is completed, if the patient is undergoing a bilateral mastectomy, the reconstruction begins on the mastectomy which is finished, on the side where the mastectomy is finished, while the other mastectomy is going on. Obviously, this is done assuming complete oncologic safety, and all the final steps of the reconstruction wait until any intraoperative pathology is reported, such as frozen sections, lymph node biopsies, etc., so that the reconstructive surgeon is given the final word by the mastectomy surgeon that yes, it is safe to proceed. A mastectomy will typically take anywhere from 45 minutes to 2 hours per side, and the reconstruction usually takes about the same if it is non-autologous. In other words, if the implants or tissue expanders are involved. Autologous reconstruction typically takes longer. It could take anywhere from 3 hours to longer, again, depending on what techniques are used.